get started and let people join as they're able to. For those of you that are here, thanks for joining us for our community conversation. I wanted to start us out with just an intro for our new leadership team for 2025. So I'll be stepping into our chair role, and Brittany Hewlett-Lyons will be moving into our past chair role. Shelley Dalton has joined us as chair-elect. Misty Schmidt is now our secretary, and Betul Janchevesh has joined us as our early career professional representative. Hannah, did you have a hand up? Oh.
I meant to do a celebrate for the.
Oh. So this is our new leadership team. And I wanted to plug real quick that the call for proposals is open still for our annual conference this fall. As part of this meeting, at this time of year, we typically will open it up to the group to see if anyone has any ideas for submissions they'd like to put in case they'd like any collaborators to join, and we can see or pull through the group if anyone wants to join those projects. So if you've got something in mind and you're interested in submitting, would like some collaborators, feel free to drop that in the chat and we can chat about that while we're all here. We do have, I think, 2 or 3 more weeks until the deadline, which is Saturday, March 15th. All right, now before we jump into our conversation about family-centered care, we wanted to see what everyone thought about webinars you'd like to see this year. We typically do a webinar quarterly. So does anyone have any suggestions for topics that they'd like to see this year for our webinar times? Use the chat, whichever you prefer. Thanks, Lisa. If y'all do think of anything throughout the rest of our conversation, feel free to add that in and we can chat about that. All right. So for the bulk of our conversation today, we wanted to just have a informal conversation with the group about health system changes that would be helpful and more supportive of family-centered care. So Neftali had came to us last year and asked us to put together a work group with the goal of identifying shifts across all levels of the health system that would better support family-centered care approaches being the standard of care. And so our goal with the work group is to come up with a set of recommendations, deliver that back to the CFHA leadership, and they will use that to inform CFHA's programming and advocacy efforts. So we wanted to get other people's ideas about what sorts of things or changes would need to happen at the health system across any level to better support family-centered care. And so that might be changes you'd like to see in a system, or it might just be barriers that you're coming up against, and we can brainstorm together what changes might address that. So the different levels that we've considered so far are operations, finance, technology and EHR, training and curricula, research, and then policy. But of course, if you have other ideas of categories we've missed, we'd love to hear those ideas as well. And for anyone for more of a long-term basis wanting to participate in the work group, we'd love to have any and all ideas and perspectives. So if you're interested in continuing the conversation with us after this meeting, pop your email address and your area of expertise into the chat and we'll reach out afterwards. But I'll open the conversation up here for us to have a conversation together. Here are some of the ideas we've already tossed around in our work group so far. So if these jog any ideas for you or you have other ideas, I'll open it up to the group. Awesome. Thanks, Lisa and Melissa. Awesome.
I want to also just add, Lisa, for the group. I know that CFHA, they're wanting us to develop this because they're wanting to kind of put some backing behind any of the shifts in policy to support a more family-centered orientation. So they're kind of really looking to us to share our expertise so they can determine how they might be helpful in relation to advocacy or policy development, things of that nature.
Yeah, Thanks, Brittany.
I think one of the things that I want to see more of is including family members that aren't just child-parent relationships. I hear a lot about minors and parents being involved, but I hear very little from CFHA about including family members that are just adults or caregivers and things like that. So I don't necessarily have answers right now of what that would be. I just think it's important for us to keep that in mind when we're thinking about these.
Yeah, I think that is really important and more recognition across the lifespan of the role of family.
Mhm.
I see, Chase, you've put in the comment or in the chat box, I think including a clinical component could be added. We could definitely split that out. Did you have certain ideas that you'd like to see within a clinical component?
I was just reading, and it got my attention that that wasn't specified. So maybe, yeah, in general, I mean, what are the approaches and interventions per se? I know you have a training curricula one, but I think putting clinical there maybe makes it more specific to,
Sure.
evidence-based stuff for clinical components. I don't know.
Yeah, definitely. And I think, Melissa, your idea would fit well under that category. And there's probably some overlap across the categories too, which is natural.
I like that it says adequate reimbursement for family-based interventions. Um, I, I just would like reimbursement for
Yeah,
family-based
any
interventions, too.
reimbursement.
Right. Without, and I just recently heard of an outpatient clinic here in town where I live, and they are no longer billing insurance for couples or relational work because
Mhm.
they don't feel like it's ethical. And I am like, that's a shame that you're put in that position. So we've got a lot of
Interesting.
work to do with
Yeah.
respect to that. Yeah.
What exactly is the reasoning about behind the ethics?
I guess because of I think and I, to be honest, I don't bill insurance, but like, and part of it is just all the difficulties involved like that. But I guess maybe the having to diagnose one of the people,
Oh,
um,
yeah.
yeah, and just yeah, and that just doesn't feel right to them. And I'm sure there are times when it applies, but having it not to, yeah, now I'm thinking about something else. But having it have to apply in order to get reimbursed.
Yeah,
But I mean, I guess that's the way, and that kind of leads into the reimbursement for anticipatory guidance and the preventative visits.
right.
They're so hung up on that diagnosis. Um, yeah. So
Yeah, I think that's a really important point from even from a policy perspective too, but the reimbursement of there's so much care that happens that doesn't necessarily have a DSM diagnosis attached to it, and it doesn't mean that it's
mhm,
not important or needed. And so maybe
yeah,
that's something we also add because couples and family-centered care, a lot of that's going to fall under that category.
yeah, yeah. I mean, there's definitely, yeah. Okay, I'll stop.
Same.
um, yeah.
Yeah, just to add to the part on insurance reimbursement and the ethics behind it, I think it comes down to the DSM diagnosis and trying to prove medical necessity. So if you're doing like, say, very traditional couples therapy, something like emotionally focused couples therapy, like trying to fold that in with the DSM diagnosis and prove that, a lot of MFTs will feel like they essentially either have to like kind of lie about the work that they're doing or lie about the
Hmm.
diagnosis, one or the other. And sometimes that just can put people into a weird spot. So,
Hmm.
because insurance kind of views it as like couples therapy or family therapy is like, is it with the patient? So, like, even that alone, identifying a patient is already like fundamentally not in
Mhm.
line with systems work.
Preach.
Yeah, those are great points.
Yeah.
What you all in your settings do from a family-centered approach standpoint? Are there strategies that you guys implement in your clinical spaces? Or barriers that you run into you'd like to implement it, but things get in the way?
I work with family members whenever I get the chance, but when it comes down to the billing, we're just billing the individual patient and
Mhm.
diagnosing the individual patient. And I think I'm just kind of like the unique one who's doing it behind the scenes. And then
Yeah.
we have residents in our clinic, so then I inform them of what's going on since they're the PCP, and
Mhm.
we talk together about what's going on as a team, but formally it's not really happening. Someone looking outside, someone from outside looking at notes or billing and things would have no idea what's going on there. Um,
Right.
it's
Yeah, I
more
think
just
that's
internal.
one space where there's a lot of room for some adjustment in how EHR is set up so that teams can orient around a family-centered approach. Like one of our behavioral health clinicians does quite a bit of couples-related work, and so for those visits, he'll have two partners there, and for some of the time, both partners actually have a PCP in that clinic, but you can only document in one partner's chart. So the PCP for the other partner isn't seeing that this care is happening.
Oh,
There's
gosh.
probably ways to do that.
Um, I don't know if this is too like in the weeds, but I've always felt like we needed to have like if we want to incorporate family members in primary care and like have it be such that, you know, when there's a new diagnosis on board or certain like points of intervention where it would be best to have a supportive person in the room, if there were more ways, operationally speaking, I guess, to bring them in, like phones in the room or
Hmm.
other like technology, so that that person too isn't having to take off work,
Yes.
and just, or you know, the spontaneously need to phone them in, phone a family member. I think that
Yeah.
would be something that would facilitate. I'm going to use my favorite David, whatever his name is from Schitt's Creek, folded in, fold in the family to the appointment. So yeah.
Yeah, that's really important. And I think COVID probably helped us with that. We have more access
Mhm.
to telehealth modalities
Yeah.
now, but it's still not a norm to make use of those. It's something that I've tried in our residency clinic to remind residents that, you know, you have access. Your EHR now has a button that has a video in it, and you can call out or send the link out.
Uh-huh.
And so I think in some ways that technology is
Yes, Michelle.
there. And so there's a training piece of getting clinics on board with, first of all, thinking of that as an option, recognizing
Hmm.
they should be using that. So maybe falling into the training category there, and then just the actual use of technology piece and implementing that.
Yeah. And I think that falls into like the training and curriculum piece too,
Mhm.
is like, you know, if you're getting ready to deliver information that a person's going to have to implement at home within the context of the people that they live with, wouldn't it be great if
Yeah,
they could just use their phone and say, hey, is there anyone that might want to listen in on this
right.
conversation that would be helpful to you? Like just
Yeah,
getting folks to think systemically, you know, not necessarily even just behavioral health providers, but the medical providers too.
definitely.
Yeah.
Yeah, I think part of that too is dispelling the myth. I think hear from a lot of our residents and faculty physicians that it's just harder when you have more family members there. I think they get scared of it. It
Hmm.
is more complex, but maybe some more training in how to manage those sorts of conversations.
Hmm.
Yeah,
Yeah, and how 2 more minutes here might save us
Some
hours in the
follow
yeah,
future.
up. Yes.
right. Or the number of follow-ups you have where your patient comes back and, you know, either they didn't understand the first time, you didn't realize it, or they haven't implemented the things that you thought they were going to implement. But if they had people at home who knew the plan and understood the condition, maybe that would be
Yep.
different. And Shelley, I see you put in the chat about the licensing restrictions. That's definitely true. Maybe there's a piece we can add to our recommendations about licensure,
Hmm.
portability across state lines, and
Yeah, I think about where we're at here in St. Louis, where it's like oftentimes people are driving from Southern Illinois, hopping the border, and then, you know, coming to our better medical system here in St. Louis.
Mhm.
But then it's like if their family's in Illinois, it's like they're less than 30 minutes away, but we can't see them. And licensing in Illinois as an MFT or as an LPC is significantly harder than Missouri. So it's like a lot of providers aren't going to do that dual licensure because there's just too many barriers. And I think in those instances, like that's not, family focused care. It's really not. And it puts up so many barriers.
Yeah, that's a good point. Group today than had registered. Any other ideas you will have or things you're doing in your clinic you'd like to see be more possible in your clinics? So was saying there's probably room for standard protocols to be put together for if you have a patient who has a new diabetes diagnosis, for example, or uncontrolled diabetes, for a standard approach of involving whoever their support people are, whether that's family or spouses. Maybe standard protocols could be helpful for certain conditions.
Yeah, and I think we used to talk about simple ways to involve families, and one of like you said, standard protocols. Also thinking like if a person like upon checkout and they're rescheduling their follow-up, is there anyone like having that checkout person or the scheduling person can prompt them, is there anyone that you'd want to have with you at that appointment? Like again, helps them. They might not be able to know that person's schedule, but it just continues to, like, if we're going to have a paradigm shift of how we incorporate and fold in
Right.
relational healthcare, then it has to happen kind of at all the points.
Every level.
Yeah.
Yeah, something I had wondered about is for the MAs or nursing teams who are rooming patients, making a habit of always asking patients when you get them from the waiting room, did you bring anyone with you today that you'd like to come back?
Right.
A lot of patients may bring someone, but they just go back to the room on their own, and then you're working with the patient in the exam room. You have no idea they have someone waiting in the waiting room that could be part of the conversation.
Yeah. Yeah.
I think
I
most
remember when
patients don't know. They don't know they can bring someone back.
Right. Yeah. I think they feel like, yeah, all the power differentials and stuff there at play. I brought my husband with me one time to try to help my blood pressure not get all crazy. And my provider looked at him like they didn't even ask who he was.
I see that so many times with our residents, and every time I'm like, did you ask who was in the room, who they brought with them? Shelley, I like the idea about putting signs up so it's more obvious to.
Yeah, that's great.
But yeah, that also goes back to just the family-centered training that medical professionals are getting so that they know the importance of family in health and health behavior and health management, and use that when they have it available to them in the room. Because it's one thing to think about it and take the extra steps to involve that person who's not in the room, but I think we're also missing a lot of opportunities even when the person is right there in the room and they don't acknowledge who that person is, what their role is in that person, the patient's life, and involve them in the discussion.
Yeah, there's just like this kind of cultural component. It would be nice if, to have CFHA be a little behind that, to kind of push or advocate for this more like systemic perspective just within the overall culture of the, primary care, specialty care settings. Because a lot of what we're talking about, everyone has to be on board, and we know, that can be a huge barrier within itself. So
Definitely. Lots of really important cultural components.
And I think adding to that piece, there's a cultural component and the stigma that is present for a lot of communities. And we add on top of that the current climate of society and people having distrust, society in general, distrust in the medical community. Am I safe in my medical clinic? That may impact engagement in general. But when we're asking to bring more people into the room, more people who have their own fears, it goes back to the operations technology part that we need to kind of innovate and advance that to help support those people.
Yeah, I think those are really important points. And obviously, and now over the last couple months, the landscape has really changed and safety has changed for our patients. Do you have specific ideas about what you'd like some of those changes to look like or what you think would be most helpful?
You know, what I've been talking about, and I'm in Oregon. I'm a clinical psychologist, but I work for a payer, and I support our integrated behavioral health programs within our region. One thing we're hearing a lot of is we just don't think people are going to come in. And I'm wondering, how do we bring our BHCs to even do some of those outreach calls and ask those questions? And maybe the appointment isn't going to be in person as most people prefer. Maybe they are virtual appointments, and just sitting in that discomfort a little bit, meeting people where they're at. So I think that's why I said it comes back to that technology piece. What do we do when family members are not able to be present or are not otherwise willing to be present for
Yeah.
very logical reasons, and wanting to validate that? Um, yeah, I think it's another shift for us. If I think back to 2020, it's a shift of how are we doing care now, just like we have to shift because of COVID.
Mhm.
How did
Yeah.
that shift happen now?
Yeah. Thinking outside the box, doing some changing workflows to be more accommodating, using more telehealth methods.
Speaking to the cultural component, um, I think some of that goes to like educational pieces. So even in that training curricula of training front desk, training medical assistants, training nurses, our PCPs, as much as we've been doing this work for so long now, we're still in this piece of how do we talk about behavioral health services
Yeah.
to assist with the stigma.
Mhm.
How are clinicians, cultural competency, that piece of it for families.
Yeah.
I identify as more of like a bicultural person. So like when you have a patient who's sitting in front of you who was taken from an immigration standpoint, raised in the US while family was not, there's going to be these barriers between them. How do we understand those pieces? So I think that kind of falls into that training piece a little bit more.
Yeah, I think that's a great point.
This is just kind of an observation, but so the last person that was speaking was a clinical psychologist. And then I'm looking at the rest of who's here today. And I think most of us are in the MFT camp. And so just, I'm not going to go down a rabbit hole too much here, but I think it might be helpful if we're really trying to change the culture of healthcare from CFHA to have more um, buy-in and participation from other disciplines within CFHA other than just the MFT club.
Yeah.
And obviously, because then we just start preaching to the choir, right?
Yeah.
And we all view things from a very systemic lens and how we'd like to include families. But if we're going to be trying to train the healthcare team, it takes more than just training the family therapy, behavioral health folks to be able to do that, if that makes sense.
Absolutely. I 100% agree.
I wonder if there's others in mind that we can think of, who might be willing to kind of join us, and if people have ideas, any allies or advocates we have.
Yeah, if anyone has suggestions, love to loop other people in. We do have a survey put together that after this, we'll finish that up and then send it out to the listserv for other people's ideas and inviting other people to join us with the work group. So that may also help us get some other perspectives as well. We deal with a lot in one of the clinics that I'm working in is we have a lot of newborns come through our clinic, but I would say the vast majority of them, their moms have primary care set up elsewhere. And so we are constantly struggling with like, how do we identify like postpartum challenges for moms, but then don't have a way to get them care because they're not set up in our clinic as a patient. And so how many times you obviously can intervene with them and support them when baby comes in for appointments, but for continued care for them we don't have as many or have as good of an avenue for connecting them to care, or even seeing for our physicians who follow up with the baby later on. It's hard for them to see that, mom is in care or parents are in receiving care for these other things. And that's the familial context that baby's in right now. And how do we continue to support that? So I think that's one thing we can consider for this as well. And we're thinking about technology and EHR and how charts of family members are connected throughout a health system or across health systems. We haven't talked much about research, but I think that's another really big area. If we get more research published on the role of family and how family is linked to health and health outcomes, I think that will also maybe help with some of the other things come in line with that. Thoughts or ideas people have? I know it's a smaller group of us, so if everyone's ideaed out by now, we don't have to stay on and stare at each other, but
I think the challenge with research is like, going back to that like kind of cultural component is that if we don't have the ability to seek external funding to research that, and we are a little bit more limited in what we can research, then I think that becomes particularly challenging. And then I think that also feeds into the inequities that already exist in the healthcare system when we're asking our patients to like do additional labor. So I don't really have a great solution for that. I just think that's something for us to keep in mind too.
Yeah, I think from the research standpoint, there's a lot of uncertainty now about what sorts of things will NIH fund and specific language that they're moving away from now. Like they don't want to see proposals on health disparities or anything DEI related, which is really unfortunate. Go ahead and wrap up there. The Families and Health team, leadership team, will be gathering all of the feedback shared today and putting that together and finalizing a survey that'll go out to the full listserv. So you'll be seeing that soon. So if in the meantime you think of other things, that'll be another place to add it, or feel free to reach out to any of us. And we'd love to have your ideas. And for those of you who are interested in joining the work group or sharing your perspectives on the work group as we continue to do this, we'll reach out to you about that. Melissa, yes, definitely. We can talk about proposals. Did you have something in mind?
It was the last
First
conference.
of all, for those of you who joined after, at the beginning of our conversation, I flagged that proposals are due in 2 or 3 weeks for the annual conference. And so creating opportunity for people to share ideas and invite collaborators if necessary, if wanted. All right.
So
Melissa.
last conference, there was a really great presentation on doing single session therapy. And I loved it. But then afterwards, I visited with the presenters about how we can include families in single session therapy. And she was like, I don't know. So I would love to do a presentation about how we can incorporate families into single session therapy. This is something that I've started to do because our behavioral health wait list is like 3 or 4 months long. So I said, if you've got people on the wait list where I can meet with them for 90 minutes, even if it's once every 6 weeks or something like that, or maybe just once, then I'd be happy to help. So we started to do that a little bit, and then including family where I can. So I would love to give people resources for how to engage family in that. So I'm just throwing that out there. I'd like to do that presentation. And if somebody would like to do that with me or has ideas about that, please send me an email. And I think I put my email in the chat already. So
I love that idea. Anyone here on the group that would be interested in collaborating on that? I will gladly join Melissa if we have a group. Lisa, I saw you unmute.
You jumped right on that, Angela. I'm like, I don't know if I have anything to offer, but I would love to help and brainstorm and, whether or not there's, even if I just meet with you guys just to brainstorm and listen to your ideas, I don't need to be included in the proposal necessarily, but I would be happy to help. So yeah, it's a great idea and needed.
Melissa, I'll put my email in the chat. Do you want to lead this and you can reach out to me and Lisa and we can
Sure.
get together?
That would be great. Thank you.
All right. Anyone else have, Shelley?
Yeah, I do. One of the projects that I've kind of been brainstorming with my research lab for a little while is on how we can get better at assessing for mixed episodes in bipolar disorder. So we have a community collaborator right now who's a trans individual who has bipolar disorder that's been kind of informing our project. And so we're hoping to do a little bit of data collection, maybe doing a qualitative survey, but if there's somebody who would be interested in collaborating on that, our hope is to eventually use that to teach back to psychiatrists and GPs, et cetera, to kind of make the assessment of bipolar disorder a lot better. Because mixed episodes just oftentimes get misdiagnosed as MDD with GAD, and it's just not helpful. It's missing a lot of people. So we're hoping to develop some actual materials, like developing like symptom cards, where we could then use the symptom cards to kind of creatively educate. So if anybody has a passion on the education side of things, I would love to collaborate.
That's a great idea. I wonder also if Betul might be interested in that also. I know she couldn't make it today, so maybe we can bring that up to her.
Yeah, I can shoot it over to her too.
In a chat saying that this is a hot topic also in pediatrics.
That was in reference to the single session. Apologies.
Oh, sorry. Caught that late.
I was quite interested in the bipolar topic. I teach family interventions at the university in the UK with bipolar and psychosis, so I kind of come at it from a slightly different kind of angle, and it's a fairly established training that we provide for clinicians working in what you guys would call specialty care in the UK, particularly in early intervention teams. So I kind of have got an interest in that area. So yeah, I'm quite happy to kind of jump into that.
Yeah, we were actually just talking in our lab meeting yesterday about how it's being done so much better outside of the US. So I think that would be right in line. So I'd love to get your email.
Yeah. I think I'll send it to, is it, let me put it in the chat. That's the easiest thing. Let me do that.
Yeah.
Great. Thank you. I'm excited.
Technology might beat me, but I'll do it.
David, I don't want us to log off before you get a chance to do that. Well, thank you all for your perspectives today. I think we've got a lot of really great information to take us to the next step. So I hope you all have a great rest of your day. Thanks for joining.